Sarah. I'm not quite sure why I was asked to do this, but I have been, so here goes. I'm David Ross. I'm a GP in St. Field, and I also co-chair the multidisciplinary team project board for the Down Federation and Southeastern Trust, which obviously has an overlap with what we're talking about today. So that's basically who I am. Bear with me if the technology doesn't work completely well, and bear with me if my internet freezes. We don't have fiber optic this distance yet, so it does tend to get a bit clunky. What I'm going to do first of all is just very, very quickly run through our panel, just basically to say who you are and what you do. So I'm just going to run down it quickly. Michael, you've already met, but I don't think you probably need another introduction, or do you? Julie?
Hi, so I'm Julie Anderson. I'm a consultant psychiatrist in the Northern Trust in the Newton Abbey area. And I suppose I'm involved in different things with the medical students at Queen's when they're doing their psychiatry placement, and some stuff as well in postgrad sort of training within psychiatry. And I suppose my real passion is around kind of perinatal mental health specifically.
Okay, thank you. And Stephen?
Hi, I'm Stephen Browne. I'm the mental health lead for the Derry GP Federation, which has one of the 2 pilot sites for the multidisciplinary team involvement within GP practices.
Thank you. And next one I have on my list is William.
Good afternoon, my name is William Delaney, and I'm the head of service for Bluestone inpatient units in the Southern Trust.
Okay, and Rachel?
Hi there, sorry, I was just trying to get unmuted. So yeah, my name's Rachel Bukovska. I am here with, I suppose, the patient perspective. So my experience is experience of having mental health difficulties for a very, very long time. Thankfully, eventually ending up in a place of recovery, or at least hoping to stay there. I would have had access to pretty much every service available at some point, including several psychiatric admissions, but I'm very pleased to say that I haven't had a psychiatric admission for over 5 years now, so things are going well. And as well as that, for the last 8 years or so, I've been involved in facilitating training courses on many, many mental health topics with practitioners, service users, patients, clients, carers, all of the above.
Excellent, thank you. And last but not least, Nigel.
Yep, good afternoon. Thanks for the invitation. I'm Nigel Ruddle, not Neil Sinclair, who would have been here. Neil's otherwise employed today. So I'm Nigel Ruddle, I'm medical director for the ambulance service across Northern Ireland, although I come from a GP background. Dialing in from home here, so I apologise if my own support worker in the guise of a large German Shepherd appears at some stage in the background. Hopefully he'll behave himself.
Okay, thanks all very much. Good panel. We've got quite a few questions coming in, and in case we hadn't, I jotted a few down of my own just to get things started. And actually the first question that's come in is a big overlap with one of the ones I had jotted down, and it's how can we ensure further rollout of mental health practitioners in primary care is prioritised and patients can access the right intervention at the right point of need, not at the point of availability. And for those of you not aware of the multidisciplinary approach, this is about embedding mental health workers and social workers in GP practices with links, developing closer and closer links with trust, mental health services, and also the community and voluntary sector, social prescribing, etc., but actually putting them in the same building and working hand in hand with GPs. So how can we ensure that that continues? I'm not sure, we probably need someone from the Department of Health here to answer that, but let's throw it out to maybe William first, because this obviously does have an effect on the acute services as well. Sorry, my sub question to this is, do you think this is the right way we should be going?
Yes, I think it's the right way we should be going, because as you say, how do we get the right service to the right person at the right time? It's almost too late by the time there's the, our inpatient world. We want to try and prevent people coming into hospital as opposed to having to go into hospital. Ultimately, there is sometimes people have to go into hospital, but how can we reduce or prevent or, you know, enable a person to stay in the community and not come into hospital? That's a good question. I think obviously the GP Federation team's key. Looking at primary mental health is also key. This is connected to home treatment crisis response services. I think you're right. Dr. Ross is very, very happy for the department to come here. I mean, it's a very, you know, it's an aspiration, I suppose, that we would try and achieve, try and keep people out of hospital and how we provide services to the right people at the right time. But it's a very difficult thing to achieve. So I'd be keen to see what other people's thoughts are around it, maybe.
Okay. Certainly from a GP point of view, working with our mental health team is fully now recruited and working, and I have to say, I think it's fantastic, especially with the social determinants of, and the people who have social aspects to their mental health problems and their mental well-being, but also the social implications of the mental health problem as well, and having it under one roof is a godsend to us. Maybe throw that to Stephen, seeing you are part and parcel of this mental health rollout in primary care. How is it? Yeah. How is it for you?
Yeah, we were, as I said, one of two of the pilot sites with this project. This project, you know, I'll not preach to you, David, because you're fully aware of this. But basically, this was a Department of Health initiative, and it's the federations, which are GP led and funded, took us on board about trying to get MDT teams within GP practices who are community facing, and basically they're first responders. Now the multidisciplinary teams are made up of social workers, mental health practitioners, physios, pharmacists, and it's about how we integrate, as we say, community facing and first responding to the wider population, to the community. These guys here are supposed to be, you know, what we are looking at is being sort of timely and appropriate and accessible. I think, and Michael or William, I think that's what you're getting at there, the accessibility at that point of contact. For us, we are a fairly big federation. We have 28 practices in the Northwest in Derry, and we have roughly one mental health practitioner for every 10,000 patients. So, you know, it may not seem a lot, but it's about that point of access for ourselves and for the patients. How it's going to roll out, the mental health strategy that's been talked about a lot today, and I have to say it's still in draft form, and it's important that people see that strategy and actually comment on it. So there's an opportunity to comment on this, folks. So make sure you take this opportunity to get your views on mental health. But certainly look at parts of that will very much gear towards how GP federations are going to be working, and trying to refocus primary and secondary care and reorganize primary and secondary care around the work that the GP federations do, and that's a big player for us. And again, one of the other aspects is as well, the talking therapy hubs that are widely used in the region. They are now going to be based within primary care, and it's about accessing the multidiscipline in the primary care setting. So it's going forward. It would be nice to have somebody from the Department of Health on here to answer all of those questions, but that's never going to happen this side of Christmas or whatever. So as I say, look, in terms of rollout, as I say, there was 2 initially as a pilot, Down and ourselves. Now that has expanded, and we are now on 5 sites with the idea that this will be rolled out further. I think the idea is that it will be rolled out to all 17 federations, and it's about how that's going to happen, and the length of time and funding and all the rest that goes with that. I have to say that there was talk earlier on about how this impacts on core services, and that is always a worry for people. We are core services as well. You know, we may be based in primary care, but I very much class us as a core service, and it's about how we make those links between ourselves, secondary service, all the interface stuff that goes with it, and ensure that, look, at the end of the day, the patient is the center of all of this, and that's what we're looking at, and it's and for all ourselves and everyone out there, it's patient-centered focused.
Okay, thanks very much. I'm not going to ask everyone to answer the question, because otherwise we'll be probably just get one question answered. But before we move on, I'm just going to ask Rachel the last part of my question. From a patient perspective, do you think this is the right way to go? Sorry, you're still muted.
Is that it now?
Okay. Yeah, that's you now.
Yeah, definitely. I think it's the right way to go. Just as I was listening there, I was thinking that what would be most important, I think, for people accessing the services is even today, what I've heard from community pharmacists and dentistry, and all the different kind of elements in different areas where people are available for help with mental health and have experience of helping people with mental health. I think for people to know how easy it is for people to be able to access some kind of support that isn't just traditionally going to the mental health route. But definitely knowing that there is someone mentally health trained within the GPs makes it definitely a far more kind of approachable and easy to access service.
Okay, thank you. I'm going to move on.
Can I make one very quick comment, very quickly? I suppose just from a community mental health team point of view, I suppose, just to echo what people have said, I think it's definitely a brilliant idea. You know, it's obviously just getting it up and running embedded, but just from a simple practical point of view in all aspects of life, if you have a point of contact, it makes everything so much quicker and so much easier. So, you know, for example, my sort of interest in perinatal mental health, there's one of the midwives in the Northern Trust who I just torture if I have any queries, and she will always point me in the right direction. So I think it'll be the same, you know, idea within the GP surgery, if there's a mental health point of contact as such, that, you know, they can be sort of helping with that really much better link and communication just and relationships kind of between the GPs and the mental health services.
Okay, thank you. And I'm going to come back to you, Julie, now, because the next question is, how can we reduce the long waiting times for mental health presentations?
I suppose I can only talk about the Northern Trust because that's where I work, to be honest with you. So I have no idea what shape waiting times are in any of the other trusts in Northern Ireland. And I suppose specifically I can only really talk about the community mental health team sort of services such that I work in. Now our waiting times for an assessment with the mental health team is sort of less than 9 weeks, and usually people will be seen at least for an initial assessment much sooner than that. And obviously if there's some sort of urgency or emergency, they'll be seen sort of within a week. So actually getting people seen, from my point of view, working in the community mental health team, I know other people might have different opinions, but getting people seen for that initial assessment isn't a big problem as such. They can be seen really sort of very quickly. I suppose the bigger difficulty from my point of view is actually the ongoing reviews and the kind of work you're wanting to do with people, because you can be sort of so busy with such big caseloads for the nurses and social workers in the teams that actually they're not seeing people as often to be able to do really useful intensive work that they want to do. So actually the sort of number of people that they're trying to sort of help and manage is probably a bigger issue than actually getting seen in the first place. Our longer waiting list for psychology and maybe other services sort of might be different. And I suppose a big part of that whole issue, I suppose, is kind of developing good links with lots of other areas within the community and voluntary sector and with the GP surgery and all the other sort of counselling services that there are out there. Because actually, and I think William said this at the start, a big thing is just getting the person seen within the right service quickly, rather than them waiting for maybe 2 months to come and see a community mental health team, actually realising there's other things that they should, you know, would work better for them. So, you know, I think a lot of it is getting those sort of, you know, links and understanding of what exactly there is out there, so people are actually sort of pointed in the right direction right at the start.
Certainly, we've very quickly come across the problem of, you know, how do we stop assessing people 4 times before we actually do something? And again, we're beginning to, those are the questions and hurdles we're beginning to ask. I'm going to ask Nigel about waiting times. How is it for you guys? Right at sometimes the most acute crisis point that arises. You're obviously seeing this at a very different end, or a very different part of a situation. Waiting times for you?
But our different view on waiting times is obviously we're not doing general referrals into the services. We encounter a patient because we typically ring 999 and we're looking to access something there and then. It's interesting what you said about the support out in primary care, David, because normal primary care is open 5 days a week, Monday to Friday, and sort of in office hours. So the majority of the actual week is in essence out of hours, and we have a significant workload in terms of mental health issues within the ambulance service. Over 10% nationally of ambulance calls for 999 calls are related to mental health, and I suspect that has gone up in the past year. So we often are a stopgap for people who have difficulty accessing services at other times or who aren't sure where to turn. And you've heard already about our efforts with the MAT team, which I think is great. What I would love to see is regionalisation of these sort of approaches. We have pockets of good practice. I think we suffer in Northern Ireland from being divided up, and it's a Northern Irelandism that everybody wants their own special way done in their own area, whereas I think we can look at what works well, and as a regional service in the ambulance service, we cover all of Northern Ireland. We would like to see the same sort of accessibility and standards rolled out right across that. We are looking at employing our own mental health practitioners within our control room to potentially de-escalate situations at the very point of contact. We have historically, and we still do, pass calls to Lifeline, who we find a great benefit. But clearly where there are significant concerns that somebody is at risk, we respond as an ambulance service. And that's when things start to get tricky. There's no doubt we have difficulty accessing the acute mental health team in a very timely fashion when we are out in somebody's living room. We have to involve the GP. We have to involve the approved social worker. Occasionally, although we try to avoid it, we have to involve the police as well. But that, from my perspective, and I know from a GP perspective, can be a very complex situation when you're trying to deal with a multitude of calls.
Okay, which leads us nicely on to the next question, because obviously that's the sort of situation nobody wants to see anyone. So much of what we've talked about is intervention. What about prevention? How does prevention fit into the overall strategy, and how is it fitted in different parts of the country? So I'm going to actually throw that one to Michael first of all. And because obviously in your neck of the woods, there has been quite a lot done about prevention.
Absolutely, and I think that is absolutely the core. I think one of the things we've realised in Merseycare is when our chief executive Joe came to the organisation 7 years ago, we were 6 to 7% busier clinically every single year, and that was before COVID. The mental health surge we're anticipating in the Liverpool area following COVID is a possible 30% increase to already overburdened clinical services. It's not sustainable. It's going to fall over. Even though the money's ring-fenced, everything costs more every year and the demand is going up. So I think the thing for us around prevention is, not only is clearly prevention a much better outcome for the individual because we avert the messiness of crisis, but it absolutely is essential if our systems are going to survive. The work we're currently doing at the moment, for example, with secondary mental health services, is we've a team of people working on our community mental health team caseloads. So we will have around about 500 to 1,000 referrals every week. A list of people will come to us that we're proactively reaching to. Now there are secondary services already, but the point is those people have been identified through the use of a digital tool as actually the need not being particularly clinical. So actually by arresting any further deterioration in their need, and by providing the appropriate lower level early help, release the clinical capacity for the COVID surge in secondary, and similarly moving more and more into the preventative field. The work we're doing in primary care, I'm willing to bet you GPs probably haven't got enough colleagues to cope with the needs of all of the communities you currently have. what we're finding with the work we're doing around social prescribing is, again, we're releasing capacity within GP time in order to actually deal with the appropriate level. And I think it's really interesting to hook that question, prevention, back to the first question about is this the right direction? Absolutely, that primary care liaison between secondary mental health services is key. But I wonder with some of this stuff whether the GP surgery is the best front door for the social and community stuff. Talking to GPs in our neck of the woods, they will say, a huge number of the issues that they're being presented with by people who are coming through the door, they don't have the answer for, and that's why they really welcome being able to refer to a social prescriber. But in our Life Rooms model, what we've tried to do is plant a hub at the heart of the community that potentially gives you a social front door, and then as and when is necessary, you escalate through that clinical door.
Yeah, sorry.
No,
yeah,
no.
I mean, whenever we were developing the MDT model and we did the scoping exercise with Geraldine Strathday actually came over to lead the mental health part of that. And the link with social care and the community and voluntary sector was there right from the outset. And as GPs, we were a bit worried about, what does this mean, et cetera, et cetera. But we were quite keen that we had the access to people who knew what they were doing and could connect to other people who knew what they were doing. But we didn't want the GP surgery to be the only access into those services. So it was opening a door for us, but it certainly wasn't closing a door somewhere else.
No.
And I think that's very important for anyone who rolls that out. So I'm going to throw the same question to Julie. How do we start looking at more prevention, and maybe just especially in your special interest area of perinatal mental health?
Yeah, so I suppose the idea of prevention is brilliant, but it's a tricky one, and I suppose it's essentially a public health message, and maybe we need our colleagues in the Department of Health on again. But I think a lot of that is about what Siobhan O'Neill was talking about at the start of today, of actually getting the message out about the basic things. So for example, I had a message from just a friend last night sort of saying she was kind of just struggling a bit more this week with lockdown and everything else, and I was messaging her back and forward, and kind of turned out after a few minutes she literally hadn't been over her door at all this week, or the last number of days anyway, not because she was shielding or anything like that. And so I suppose people who know me, she got a bit of a sharp response from me of kind of, well, you're going to feel awful if you haven't even been getting out for a bit of a walk every day. So she got a bit of a lecture. But I suppose it's trying to get across a message, which is a public health campaign, but we all have a role in that in our social, as well as our work environment, I think, of just people needing to get the basics right around, getting fresh air every day, trying to keep a good routine of sort of around your, keeping an eye on any alcohol use, avoiding substances, looking after your diet. It's all those things that are so basic in some ways, but then often people kind of ignore them. And those sort of really simple things and sort of ideas around trying to keep some sort of structure and routine, particularly when those have all gone with lockdown, are just so important and can make a massive difference to anybody's sort of emotional well-being. So as I say, some of that's a kind of big public health sort of issue, obviously, and campaign, and there's lots being done around that with sort of simple things like Take 5. But I suppose at the end of the day, we all have a responsibility in that, and whatever, as I say, in our own sort of social and personal lives, as well as our work and our work sort of roles.
Okay, William, as someone who's spent a career in acute services and things like this, you must have seen quite a few cases where you've gone, oh, if only this had happened, we didn't need to be in this situation. Prevention, how do we do it?
Yeah, fair point. I think building on what Julie said, absolutely. I mean, it's more than a public health message, it's more than primary care. It's back to the first presentation around, society and intergenerational traumas. I mean, it's a massive, it's a massive field in its own. But, we do see people coming in the heart. More people are getting in hospital at the moment are generally very more mentally unwell and haven't been in hospital a long time. And it's attributed back to COVID. It's back to the loss of routine, back to that social contact, back to that, there's no structure. You know, I think, although they seem very simple, they're key things to do. You know, people don't sleep well, they're up, it disrupts their, it affects their mood, and they're, you know, they're not taking their medication properly. It's so multifactorial that, you know, it's the simple things that keep us well. We have to focus on them. And then I suppose that goes back to the work that Michael does, goes back to recovery colleges, goes back to primary care, goes back to, you know, friends and family and carers and service users and advocates. It goes back to everybody. But that's the, I suppose, the most important thing for me is probably structure and routine and the simple things, you know, social contact, you know, keeping in touch with somebody. I don't know how we do that, but that's a key thing. Loneliness is a key thing at the moment. It seems to be coming through the ward. People are very lonely, and it causes a lot of distress. But I don't know how we crack that.
Okay, I'm going to phrase this slightly differently now, but I'm interested to hear Rachel's perspective on how we've talked about reasonably simple things there, you know, lifestyle changes, big public health messages. How do we get that across successfully from a patient perspective? And do you think the public health messages that have been given out in the last 5 to 10 years have been effective? And if not, what would be effective? That's a lot of questions. I'm sorry about that, but it's all basically linking. You're still on mute again. Can you unmute? That's perfect. Yep.
It wasn't me that time. It got muted somehow along the way. But
okay.
That was a lot of questions. I think I was just thinking and listening to all the other different perspectives on prevention there. I have to say that I absolutely love the work that the Merseyside people have been doing there. The life rooms, that's right up my street. I think the only way that people can prevent poor mental health, especially if they've experienced it already, is by education and learning the things that work, and learning to, I suppose, the things that Siobhan mentioned this morning, the self-regulation and the self-soothing, the emotional regulation. People don't always have the tools to do that unless they're shown at some point. So education for me would be a massive thing for anybody with mental health difficulties, or even before any mental health difficulties come out in people. So it's fantastic to hear that it's going more into schools and things. What I love as well about the life rooms is the fact that you can go somewhere that isn't just a mental health place. I think particularly here in Northern Ireland, there's always been such a stigma around mental health. And even to this day, a lot of that still remains. There can be a lot of, when people are in crisis, they can be seen as maybe attention seeking or manipulating, or, you know, all of those negative things are still there and still seen. But I think just that kind of wide approach where you're looking at people that it's not just mental health focused, but making it very, very clear that actually the tools and the skills and the education is here for people to learn to manage their mental health, and the kind of the acknowledgement that mental health difficulties can affect anybody and everybody, can help remove that stigma.
And how do we improve the message about getting things that will help, or just avoiding things that we know will be harmful for people's mental health? And I'm thinking especially about alcohol and recreational drug use.
Yeah, that's the I mean, obviously that's a real difficulty for so many people. And I think with mental health difficulties, when people are in pain, the natural instinct is to avoid that pain, and to cope in any way that you can with it, which leads to all the kind of unhelpful things like the alcohol or substance abuse, or even things like eating, like not going out, not facing the world, not sleeping, all of those kind of things. Getting the message out is a tricky one, but I think there's been massive steps made through all the social media platforms. I think you have to kind of keep in mind that there will be part of your community that will, probably the younger generation, if I'm going to stereotype here, but would have more access to the things through the social media and things like that. So also keeping in mind that you need to publicise these in the traditional ways through the GPs and through all the various sides of the health service. I think it all has to be done in a very kind of destigmatizing way that's kind of opening it up for everybody, that it isn't just, you don't have to think about these things because you've got a mental health problem, or these aren't applying to you because you've got that mental health issue, but keeping keeping it out there that these are tools that everybody needs, and especially in this pandemic where so many people have been thrown into the same boat, where actually there's something that as a huge group society is worried about and anxious about, and everybody is kind of facing a lot of the same difficulties. I think might make it even more kind of wide reaching, that it isn't just because you've got a mental health issue.
Yeah, I know certainly destigmatizing it is huge. I've been around for quite a while now, and certainly I get people coming into me being much more open about what their problem is, sometimes disarmingly open about what their problem is, that quite frankly 25 years ago just wouldn't have happened. You would have had to prize it out of them and, you know, follow them to see how much they were actually drinking, as opposed to now they come out and say, like, I've got a problem here and I need to talk to you or someone else, or can you put me in touch? Okay.
Yeah, and you were asking about the public, sorry.
Yeah, go on ahead, Rachel.
About the public health messages getting out there, and I think something that was very effective was when the TV advertisements, there was the kind of the young guy that had the mask that kind of came on and off, and all those kind of, I think the TV was a really good avenue for that, and the fact then that it linked into all of the kind of online and all of the like the paper materials and things like that. But that real message kind of linking across all of those platforms, the whole it's okay not to be okay and it's good to talk, and all of those ones are making it a lot more open for everybody, I suppose, in society to maybe feel that bit easier about talking about things than we used to.
Okay. Stephen was wanting to come in there, but I'm going to ask him the next question anyway. So, yep.
Yeah, just on the last bit, and I think it's, I mean, everyone will agree with I think with this point is that, you know, in terms of how we're looking at prevention, isn't necessarily about what we're actually doing now. With all the guys that's here and the panel that's all represented here, and you know, in terms of we are all focused on what we're doing at this very moment for people who have got problems and who are present to us. It's that unmet need is what we don't have the opportunity to look at, and we don't really get an opportunity to invest in that area. And that's why I don't believe that the likes of William and Julia and myself, who are at the forefront there, that we are seeing the people who are actually nearly too late to see for preventative purposes. So it's about how we tap into the likes of Michael, the likes of the Scandinavian models would deal with kids with alcohol and how we address those issues. It's about looking outside of that box, and Rachel is right, you know, in terms of how that hits home is with these stark and hard campaigns that go forward with that. So sorry, that's just a comment. I didn't, you know.
Okay. You're going to get the next question anyway.
All right.
Which is, I mean, you've obviously spent, what, 27 years as a mental health nurse. Mm-hmm. Question about how we can integrate and promote career pathways in mental health in primary care from undergraduate, postgraduate education programs. That's a question we've been asked about doctors, about nurses, about pharmacists, about physios, and now the different subspecialties after. You know, working in the practices and embedding in primary care, how do we promote this as a career pathway? Whether it's trust employed, federation employed, that's not that relevant, but it's where you're working.
Yeah, and again, it's about, and I'm going to sound like it's making this these posts attractive, making this a job attractive, and maybe it goes back to where people are, this idea of mental health being a sort of stigma that goes with it. But you know, the role that we do and the role that all the other guys do is about, it's community focusing, about helping people within that community, and it's about trying to get that forward as more this is a community-based role that you're doing, and it's about how we're trying to help people. People talk about the vocations, and it's, you know, about that's, it's always been in you and whatever. I don't believe that's so. I believe that everybody has got a role within the community to work with, and it's about your feeling about where you're going in that role. Certainly, I know that GPs are struggling to get, you know, and to get more GPs. And it's about how we attract it up and make it more attractive to people. Certainly, I don't know, Julie, you'll probably come in here about the amount of work that you're doing, and about, you know, 50-hour week is not unusual, 60-hour weeks is not unusual, and especially doctors, they're, you know, we can all see it there in A&E and whatever else, they're, you know, the hours that they're working and whatever else. It's how we protect those guys as well, and about how we make it more in line with what's happening for their lifestyles, especially young people. Young people do not want to be, younger generations do not want to be coming into a job and be working 140 hours a week or whatever it is, you know, and finding it really difficult to have any life outside of that. And they hear those horror stories. That's the problem. And historically, they've heard those horror stories, David. So it's about how we can get that message out too. And we have to go into universities to do that. We have to go there. People like yourself, people like Julie, Michael, or whatever else. We have to go in there and say, look, this is what this job could do for you, and how can we protect that?
Okay, yeah, just very briefly, just through the same question maybe to William and Julie. Primary care exposure for a variety of mental health practitioners, be they doctors, nurses, OTs, social workers, etc. How do we get primary care exposure from a trust perspective? Don't all rush at once.
So I suppose from it's the same as anything. The earlier you kind of intervene, or whatever, the better. So letting people know about the jobs and opportunity things that are right from sort of school age, obviously, and then whatever profession or training people go into. We've all responsibility, I suppose, for myself, thinking about the psychiatry placement they have, and we would run sort of additional special study modules in mental health earlier in their sort of undergraduate training, those sorts of things.
What about placements?
So I suppose I'm talking about Queen's specifically, sort of in Belfast, where sort of earlier they would do their main psychiatry block as such in the 4th year of their of that, and they have opportunities to do other sort of short modules in sort of 1st and 2nd and 3rd year that are sort of linked to mental health. They're quite broad ranging, and I suppose that just gives an opportunity to get a little taster more than anything else. In that, there's obviously the new medical school opening in London Derry this year, which will have sort of a lot more 70 new sort of places, and I suppose there's a hope there that there'll be more people who will maybe go and sort of in towards GP level from there potentially as well. But I think it's sort of individual responsibility of kind of being passionate, enthusiastic, and taking opportunities to be doing anything within schools and careers and universities and those sorts of things.
And William, for undergraduate placements, where people are already going down the line of mental health training, but placements in primary care as opposed to secondary care, what happens in Southern Trust?
There's an increasing presence now and recognising primary care, certainly I suppose in the undergraduate curriculum. I think it probably, I suppose, regards to mental health nursing, it's now much more focused on psychotherapeutic interventions. It's more specific around, the likes of CBT or DBT or whatever. Years ago when you trained, you got exposure to it as opposed to actual opportunities in it. So I think there's much more opportunities for undergraduate, pre-registered nurses that are now qualifying to engage in primary care. There's much more opportunities in specialist roles like CBT or specialist nurse practitioners or advanced nurse practitioners. So it's a process that is evolving, and I think it's recognising that we do need advanced nurse practitioners in primary care, specialist nurses, and it's not just a generic nurse anymore that goes out and works in primary, that they have a unique set of skills. That primary care it's almost like a specialist area on its own. So there's a change, but it's like everything, it takes a bit of time for that change filter down, but I think there's definitely.
Certainly, again, in the MDTs, and Stephen may or may not agree with this, but I think certainly you being the first point of contact in a practice where you're used to quite a high turnover of calls as well, where you're trying to assess that quite quickly. It is a very different role to, you know, have already been a second point of contact. And it's probably something that I think everyone probably slightly underestimated the difficulty with. But I know when we were initially talking to the department about the grading of these posts, that's why we said we need experienced people to do this. Because yes, this is first point of contact. A lot of it may be at the less severe end of the spectrum, but some of it isn't, and some of it is very, very severe. I'm going to ask Michael, in Merseyside, what about exposure to the whole gambit of people involved in mental health at undergraduate and postgraduate level in primary care? And I mean doctors, nurses, social workers, OTs.
Absolutely. Interestingly, we currently, with our social model, have 2 OT student placements and a social work one, and they're working into our primary care services at the moment with GP practices. I think, you know, the things that keeps coming back to me actually through some of the questions here and some of the commentary is actually we need a whole system response, don't we, to actually tackle all of this stuff, particularly around the prevention agenda. So the more we can actually get that multidisciplinary, interdisciplinary picture between clinicians and students, learning about mental health from the get-go in whatever field, because let's face it, whichever discipline they eventually specialise in, there'll be a lot of mental health, at least on the edges, if not their primary focus. But the more we can actually bring in our colleagues in education, in public health, in social care, the whole picture to address mental health prevention issues and mental health pathways, the more successful I think they'll be.
Okay, thank you. I think we're probably pretty much agreement on that. Okay, maybe time for 2 more questions at least. And I think this one is mainly about people who are living with a long-term health problem, not necessarily a mental health problem, but what mental health support is there? Or do you think there should be for people living with a long-term health problem? And I suspect long COVID is at the back of that question. I might be wrong, but something tells me it might be. Are we going to be hit by it with a tsunami of need? Julie?
Probably. It'll just be this new normal that we're talking about is going to extend to a different sort of new normal. Probably, I suppose, kind of your sort of question at the start of that, which was kind of around, you know, more broadly maybe with chronic sort of physical health problems, and obviously it sort of harks back to a point that Dr. O'Neill or Professor O'Neill made right at the start as well about sort of your mental health and your physical health just being tied up together. You know, you can't separate them out. And certainly if you have a chronic physical health problem, you're much more likely to develop problems with your mental health and vice versa. I suppose from my point of view, and this is just well, personal as well as professional, you know, it's about sort of trying to upskill in some shape or form or get the right professionals involved within cancer services, within, you know, whatever sort of the other diagnoses are, because if you can have psychology sort of input or upskill of other staff in those particular physical health areas that are able to kind of provide support and input and do some basic work around mental health, they're in the best place to do that because they know the person and they understand the physical health condition really well before it's sort of, because what you don't want to happen is for sort of any mental health difficulties that are developing to sort of be ignored as such and then become more difficult to treat. So again, how we do that, you know, there are sort of pockets of where we'll have, you know, there'll be sort of psychology within chronic pain services or, you know, different things like that. I think that's definitely a good model.
Is there a danger that we medicalize things that are part of life?
Absolutely, absolutely. Do you know, and I suppose that's what I was sort of half saying not very well about the new normal, because there's a general increased level of anxiety maybe across all of society right now, do you know, because of COVID and our loss of routine and all those sorts of things. and that, you know, you can't sort of say that everybody has an anxiety disorder or anxiety illness. So absolutely, and again, it harks back to kind of, you know, pointing the person in the right direction at the start rather than necessarily to, you know, even the GP or the psychiatrist, but some of that is about knowing where those pathways are and where those different supports are.
Yeah, I mean, if we look at other conditions, again, having been a wee bit long in the tooth, having seen this happen with asthma and lots of other conditions where we bring the diagnostic criteria wider and wider and wider and wider, and actually what we end up doing is diluting the resource available for the more severe end of the spectrum.
It's going
to be a difficult question, Rachel.
Sorry, David, can I just say, in terms of and this harps back to, is there going to be a tsunami? What we're seeing at the minute, you know, in terms of numbers through the door, is we are relatively stable in terms of, it's quite a lot, I have to say, but it's stable. There's been no major, COVID has had some in presentation, but it hasn't had as much presentation as we thought it would have. But I certainly believe that people are just dealing with it as it happens, and when all of this stuff finishes, we might have that whole PTSD, for want of a better word for it, and that might be a major presentation for ourselves when it gets to GP land at that stage.
And I'm going to throw this to Rachel as well at the moment, and I don't want to be too controversial, but do you feel sometimes that you hear people talking about their mental health problems and you go, you've no idea?
No. No, I don't. I think that everybody's worries and everybody's stresses are the biggest issues to them, you know, and that whatever is going on in everybody's life is kind of equal across the board. You know, I was interested in the question there about the physical health side of things as well, because I'm also a type 1 diabetic, and I know that within the diabetes service, we had for a while at least a psychologist on board. And I think hearing that there was a psychologist on board made it kind of normal that actually something like this, the diabetes, impacts upon people's lives, and even just having that kind of recognition that, oh, that's normal. You know, normalizing it so that people aren't having kind of self-blame for the worries that go on with them or the difficulties that they have, taking all that kind of blame idea out of it. So no, I think anybody's stress levels and mental health worries and things that are going on for them are just as valid as anybody else's.
Okay, thank you. Nigel, you'll have seen people at the sharp end of COVID and the relatives of people at the sharp end of COVID. Do you think we're going to have a tail from this, from a purely psychological point of view? People who are waving goodbye, possibly thinking they're waving goodbye to their relative as they're wheeled into one of your vehicles?
There's no doubt, David, that has been a huge stress for people throughout the past year. You know, my heart goes out to the families, and indeed I've been caught up in this myself from a family perspective of having to, you know, somebody go into hospital and them not coming out, essentially. It is extremely difficult at the one time that you so much want to be there to not have that access, to not have that comfort. And it's also very difficult, you know, I really worry about the stress, not just to the general public, but also to those working within the health service. We've seen and heard the stories of those working in intensive care units who are doing their absolute best under these awful circumstances to act as a go-between between, you know, a dying person in intensive care, you know, trying to communicate with families via Zoom, etc. And that's taking a huge toll on those who are not encountering that just once, but, you know, sometimes several times a day, and having to work through those situations. So I do feel that there will be a lot of trauma in the broader sense for, you know, those who are left behind from a relative's perspective, but also those who are working within the system who have had this relentless wave of high intensity work, but also that mental stress and mental trauma as well.
What about your staff who may be sitting for several hours with a very sick patient in an ambulance in a queue waiting to get into a hospital?
Don't get me started about handovers at hospital.
I was giving you a free pass.
Oh, okay, that's for another day, a whole other day. Our staff are tired. I've been on the media. My usual role in the media is apologising for things, I find, but our staff are exhausted. They've been working flat out from away last February. I remember being involved with the very first patient in Northern Ireland that was diagnosed with COVID, and it just has been relentless since then. Our staff are going to lots of high-acuity calls. Despite all the conspiracy theories out there, there are a lot of very, very sick people that we're having to deal with as a result of COVID, plus all the other work that is going on in the background. And yes, the pressures right across the system, particularly in emergency departments where because of spacing requirements, it is much more difficult for us to hand over patients. Has seen some of our staff sitting sometimes with very sick patients, COVID and others, outside emergency departments, having to manage and nurse and provide for the general well-being of those patients, sometimes for 6-7 hours in the back of an ambulance, often going past the end of their shifts as well. So physically and emotionally, our staff are absolutely drained. And we recognise that's definitely not the best care for patients. They're not getting the medical interventions they require, the full assessment they require, but also the dignity that is lacking in that situation when patients are having to be toileted, etc., in the back of ambulances. And always my biggest concern is the risk to the other patients out in the community, the other 999 calls that are stacking up while our ambulances are literally stuck outside the emergency department. Often unspoken about is our control room. Everybody sees the yellow ambulances driving around blue lights and thinks of our staff stress. But throughout this, our control room, who are still getting those calls, are speaking and engaging with very sick patients, both with physical problems and with mental problems on the phone, talking relatives through how to manage somebody, and yet looking around the screen and seeing there are no ambulances to actually send to a call. And my heart goes out to those staff who work in the control room. I listen to a lot of those calls. I review a lot of the audios of those calls, and the job they do is incredible, but it takes a lot out of them.
Thank you. Okay, one more question before we wrap up, and this is one sentence. You're only allowed one sentence each to answer this, and that is, if more resource was available to the Cinderella service, which is mental health services, what would be your top priority for where it should go?
I'm going to push
Julie.
One sentence.
One sentence.
I've already got some funding for perinatal mental health services.
Okay, so you're okay. Michael?
Throughout 2021, with Robin Swan approving that. So
Michael, where would you put it?
I'm not allowed to say any more than that. Well, not I, shouldn't have said I, along with very, very, very many other people. Obviously, I have a small role in that.
Where would we put our funding? I think that two areas, refugee and asylum seeker populations have been a massive risk for us during COVID, okay. And the whole issue of digital exclusion, digital access and literacy. You know, we're creating health services and education services that can't be accessed unless you're digital, and there's massive digital exclusion issues, so those would be my two.
And that's a huge sentence because there were about 3 or 4 ands to tying the sentences together. Stephen, where would you put it?
Naturally, I'm going to go with resourcing the mental health practitioners within primary care, so that we could obviously fund and then help forward and reduce the waiting times to go to secondary services.
Okay, Nigel?
I'm actually going to agree with Stephen. The early intervention.
Okay, that's good.
I'm going to put lots of semicolons in my sentence if you're not careful. I'm going to agree with Stephen because I think early intervention, to defuse situations, to prevent them becoming a crisis, allowing these problems to fester and deepen. So anything that improves early access to services and to de-escalate, I think is a good idea.
Okay, William?
I agree. Primary or crisis response services prevent people coming into hospital.
Okay.
I'm at home.
And last word of the session to Rachel. Where would you put?
I would follow Merseyside's leads with the life rooms. That just sounds incredible to me, but also education.
For the public?
Education for the public. Yeah.
Okay. Okay. Listen, thank you all very much indeed.